So what we talked about the last time was the difference between saying substance use disorder and substance abuse, which is huge. And just to bring it back up, Harvard Medical did a study coming out of treatment court where they took professionals, like you all, sit in the room here, and they changed nothing about the demographics of the people that they would be hearing about in the treatment court, except for, in one case, saying that these people had substance use disorder, and in another case saying they were substance abusers. And it was a blind test on the professionals in the room, and doctors and therapists tended to, when introduced to these substance abusers, view them more as participating in willful misconduct and suggesting a more punitive outcome than those people who had only been introduced, and that was the only difference, with substance use disorder, where they thought that more of a medically based approach would help them better. And so that's the origin, I think, of wanting to have this discussion is language matters and how we treat language matters. The one that I think of the most are eating disorders. We don't say that people are, have you ever heard people say food abusers? I don't think I've ever heard that term. We say eating disorders, and how are they treated in our system? You know, they almost always go somewhere. They get medical help, right? They get therapy help along with it. So I think the language truly helps. I also wanted to start this out in a different way because I just, as oftentimes happens, I had a discussion yesterday with somebody. I was doing a little mini training for some social workers. And this is fascinating because here's what one of the ladies was going through divorce at social work. And we had this discussion. She went to a counselor. And she said, I'm divorcing my husband. Can you guess the questions that the counselor asked the other counselor who was going through divorce? What did she ask her about her husband?
They're both counselors?
Yeah, so the counselor is asking this woman who's going to see another professional because she feels like she needs help. So she's going through divorce.
Is he abusive?
Is he abusive was the first question that she was asked. What was the second?
Is he an adulterer? Is he having an affair? Why?
No.
Substance use? Is he addicted?
Just think about why you're here. Is he alcoholic? And she said, is this what you're talking about? I said, pretty much. Lumping, is he an abuser? Is he hitting you? Is he an alcoholic? And that's the exact term they use. And when I train social workers, that's right up their alley. I mean, I bet you can hear that in your interview with clients. Not, hey, what's going on? Does he have some issues? Does he need help? Is there some treatment opportunities available? We're lumping abusing and alcohol in the same two sentences. Like, okay, these are the two reasons to just get rid of. Now, I'm not saying you should stay with somebody. I'm saying we're lumping it with that. Now, that makes it much more difficult for that person to then view that situation in a different way. I oftentimes would ask, what have we done to address this issue so far? And whenever I say, what have we done to address the issue of substance use disorders to a family, what do they say? What's the most common response? How have you addressed this issue before?
Either we haven't or we've taken them to the emergency room.
You got it. We haven't. We haven't. We haven't? So this has been out there, what it was, like an elephant in the living room for how long? And we haven't even addressed it. Well, that's not totally true. How do families address this issue?
Yelling at him, taking alcohol away.
Denial.
Okay.
Avoiding him.
Avoiding.
Enabling.
Enabling. Did you see Karen? Can you believe she showed up again? have you smelled their breath? I mean, talk behind their back. What if we treated diabetes that way? Or asthma? Or any other medical issue? We didn't do it at all. Now, this makes it more difficult, I think, for the person to get help. They feel judged, sometimes condemned. They feel isolated, and they feel as though it's a flaw in their character. We talk about resolving shame sometimes in therapy, and this comes from, that sense of shame comes from, I'm a bad person, because those are the messages that you tend to get in the system. So I thought what we would do is just to have a discussion about how you've seen this in what you do, in the field you work at. I'm particularly interested in when they walk into the Hope Council, what you hear them asking you, right? And then you get them at a different stage, right? As part of that. You see them before they even get there. Right? What did you do?
I work with them to identify their needs for their recovery and
Perfect. Very similar, right? And as we said, you don't do anything. So,
I videotape really well.
yeah, you do. And you're tan.
Yeah.
So we hate you. Clearly you've been outside. So go away. So how do you perceive it? What do you see as the obstacles when we address stigma?
I think employment is huge. If somebody has cancer, is a parallel I like to use, right? If there's somebody that's working in your office that has cancer, what happens? Somebody sets up a meal train. Somebody makes sure that their lawn is mowed. Somebody makes sure that their kids are picked up from daycare and school and events, and they put signs in the yard and the neighborhood rallies around, and it's all these things. And then when you have somebody who's struggling with substance use, the manager knows, and the people around them know in a lot of cases, but they don't say anything. They don't offer help, and that person is probably more than likely scared to say something in fear of losing their job, because let's say they have to go to treatment, residential, let's say, it's 30 days. Let's say they have to go to PHP, and it's only offered from 10 to 1. Well, that's 6 weeks of non-work. So they don't say anything. I would love to see a joke, not a joke, half joke. I'd love to live in a world that somebody could be celebrated in terms of taking care of their substance use disorder the same way that they take care of any other mental disorder that they're dealing with or disease.
I think that's a great example, don't you? What would happen in your workplace if you had cancer and needed to leave work to go get chemo or radiation?
People would rally around you. But I think the significance of that is even other people in your family, right? That if your son has it, or in my case, my husband has he needs a new mitral valve. And people are like, oh my gosh, we're praying for him. Can I do anything for you? Can I? If it were a substance use disorder, it'd be like, shh, it's uncomfortable. It's awkward. Let's not talk about that.
And why is that?
Because we professionals pretend that we believe that substance use disorder is a disease, and yet every single day we act like it's not, because we don't address it. Because unfortunately, if somebody comes into wherever and says, well, I don't have a disease, we say, oh, okay, let's talk about what else is going on in your life. And I said this to my husband. If we go to the doctor and the doctor says, you have mitral valve regurgitation, and if he said to the doctor, you know what, my dad had mitral valve regurgitation, I know what that looks like, I don't have that. His whole circle would disappear, right? I'm not going to watch you kill yourself. But in the world of substance use disorder, we all pretend that whatever that person says is true, and that is absolute nonsense.
We let the patient self-diagnose.
Yes, across the board. And then you have the willing accomplices. Again, somebody has a heart complication or cancer, they don't go find a bunch of people who have cancer who aren't doing anything and be in a group together. But that's exactly what we do with substance use disorder, right? I drink, I'm gonna go find a bunch of people who drink with me and tell me I'm not sick. And then the rest of us, the world around us says, yeah, you're right, it's not that bad. It's not that bad. It's not that bad.
Well, we're taking this right. We've seen parallels to that with people who didn't. The statistics about non-vaccinated people for COVID and dying is significantly higher than those people who got vaccinated and dying. But the people who didn't get vaccinated banded together, like you're saying, and said, yeah, this doesn't happen. And it's sure it does. You can choose to not get help. You can choose to ignore the advice of the medical professional.
And I would say, and that's it. So professionally, the rest of the world said, take a look at the stats.
Yes.
With substance use disorder, we don't do that. Unfortunately, the professionals who are in the field, and I get it, we all need to get paid, right? We all need to get paid. So when I say to Karen, Karen, you have the disease of addiction. You have an alcohol use disorder. And you say, no, I don't. And I don't like you now because you're my therapist and I'm going to go find a different therapist. So then you go over to Bobby and Bobby says, well, let's talk about other issues in your life. Instead of saying, no, you really do. You really do. Because again, if I went to a doctor and my doctor said, you've got cancer, you need a new mitral valve, I'm not going to find a different doctor who's going to say, yeah, you know what, she was off base. You really just need to look at these other issues in your life. That's the problem. It's the rest of society, because people who are sick aren't necessarily recognizing that they're sick. It's the rest of society saying, we're going to be on board with you pretending you're not sick. Sorry. I spent a lot of the last 2 months thinking.
But that's why we're here. That is what happens. How we participate. Now, how do we break through that?
By having open dialogue, letting people know this is a safe topic to talk about and it's a safe space. I mean, all we've heard over the past 3 to 4 years, maybe longer than that, is setting up safe spaces for people for different issues, and you could list 100 of them. There's not a lot of safe spaces for people to talk about their substance use disorder unless you're already working a program and going to AA or NA or have a therapist and you're in group and you've been to treatment. But those people and those family members, I'm one of, that lost somebody to this.
Yeah.
Like I look back a couple times a week and go, probably should have told Grandma and Grandpa about Carrie. Mm-hmm. And we didn't do that because we were embarrassed and ashamed and felt like we would be looked down upon by neighbors and relatives and friends. And it's just knowing that it's okay to talk about what's going on in your life. And I don't know what that golden ticket is. If I did, I'd probably write a book, or have somebody write a book for me. But I think just having these conversations and putting them out into the ethos and sharing it with your network, and it's going to take a bunch of little grassroots movements to make a bigger movement, and I keep saying, who has to die for this to become a reality? Like, when Tom Petty died, I was like, okay, that's a big name, right? And a day later, it was gone.
Yeah.
And nobody wanted to talk about it. Michael Jackson, Prince. I mean, these are big names, and what's proven
Whitney
to
Houston.
me, it's not the name, because people are still scared about the conversation.
I think what you really need is super popular people to survive and
For
talk
sure.
about it. Not enough really big people talk about it yet, or are willing to share their story. Sometimes you see the posts of this person's had 14 years of sobriety or 5 years of sobriety, but never when they're in the depths of it or when it's first going through their recovery.
Do you know who Stevie Ray Vaughan was?
Mm-hmm.
He passed away. Great guitarist. Yeah, I loved him. And I saw him several times before he tragically passed away in Wisconsin, right? He was at Alpine Hill. And he would do a thing in his set, he was recovering, where he would talk about recovery. And he would say, I used to think when I played the guitar and I was higher than a kite, or, I was on all the stuff that I was good. And I saw him once where he actually showed a clip of him playing. And this was a guy who was great. And it was like I was playing, and I can't play. And he said, but I thought I was kicking it. This is what it sounds like to not be on substance. He said, we're sober. This is what it's like to be sober. And he played, and it was hilarious because all these people, woo, and they're holding on. And I'm like, well, you tried. You tried. I think I got the message, and we need to keep going. But it flew right over the head of the Budweiser girl, right?
And I think to continue what you were saying, like as a parent in the parenting world, no one will discuss their teenagers.
Oh, that's a great.
They will not say, my kid went out last night and came home drunk. No one is sharing that information with each other because the implication is you are a bad parent. That's a parenting issue. You did something wrong. You're a sucky parent. It is not discussed. It's so taboo. And it's having a few brave people willing to, and maybe they share it with one person, but it stays so small.
Well, let's talk about that a minute. Is that right? Did you do it when your kids were growing up?
Did I?
Well, let me tell you what I did. You can.
Okay.
Okay. So I have 3 kids, all a little bit older now. And when they were younger, and we had, I was right in the middle of youth whatever, youth soccer, youth basketball, youth baseball, dance. Oh God, dance. And you're with these people all the time. Like nobody tells you when you first have a family that you're going to spend 20 years on the sidelines with people you don't like every weekend, or may hopefully like. And so when they were in 5th grade, I gathered the parents around for my kids, and I said, "Okay, here's the deal. They're going to get old. How do you want to handle them being stupid? How do you want to handle them shoplifting, drinking, using drugs? What do you want to do?" And the parents all looked at me like, "What?" I said, "Well, this is what I do for a living. So here's the deal. When my kid comes, if you find out that my kid does something like that, I want you to tell me. I will not be mad at you. I will appreciate that." You can see the roots. And it was like a pact. And we all formed the pact. And I felt pretty good about that, right? Fast forward. Junior year of high school. And my son is playing basketball. I'm sitting in the visiting student section because the parent section is a dysfunctional place to sit. And I'm sitting there, and all of a sudden, 2 of the kids who I coached, who were in this peer group, who didn't play basketball, walked past me. We were talking about this before. Well, I could tell. They had spent the previous half an hour smoking marijuana somewhere. Because you can tell. As they walked past, first the athletic director, who did that and did nothing. And then me, I was like, and I looked at him and I said, "Guys, oh hey, coach." I said, "Come here." We walked behind the curtain in the gym. I said, "What are you doing? Why are you doing this? What do you mean?" I said, "Okay, it's me." And we formed this pact, right? So I said, "You just walked past the athletic director." And I said to one of the boys, "You have to lead the school musical in a week and a half." And I said, "He's the co-curricular guy." He goes, "Sorry." And, it was our first time.
It's always their first time.
Well, and I said, "So, how's this going to go? Do you want me to tell your parents, or do you want?" And then I said, "We'll do it." I said, "Okay, then just have your parents text me that you had a conversation." Okay. Well, to their credit, they did. And I got 2 text messages from the parents about 10 o'clock that night. "I hear you had a conversation with my kid. Thank you." One of them came over to my house the next day with their kid. We had a long discussion about it. The other parent hasn't talked to me since. Not even hello at Quick Trip. That's the yin and the yang of the whole thing, isn't it? And I have no idea why. What did I do? You know, did I call his kid a name? Did I indicate anything? And by the way, as they progressed forward, which is why we're talking about this, which one of those two individuals had more problems with substances? Right, like we're surprised. And so that's a really good direction. And so you have to risk, when you talk about this openly, do you not risk alienating a certain group, whether you're a therapist, public servant, a therapist, educator, parent? You do run a risk, right?
I think there's a whole nother level to that is getting even bigger in that families aren't mom and dad and two kids where mom and dad are on the same page and they talk to their kids when those things happen. There's often this family and this family share this child and this is mom and this is dad over here. And then what happens at this house doesn't translate to what happens at that house. And what happens at this house, this one's going to blame on that house. So there's another level to that, not just amongst peers, but within their own family as well.
We often get invited to those at 2 o'clock.
I was just going to say,
Right?
this is where you come in, right?
It's fascinating for me to continue learning more about second, third, fourth, fifth tier of what this looks like or what you hope that it looks like. But I know just from 26 years of dealing with this in emergent settings, it's kind of just crazy. You're just trying to immediately manage the trauma of the situation. You're not conscious about the words you're using. EMS in particular starts something called a diagnostic momentum, meaning if I think you have chest pain and I think it's cardiac, I paint that kind of a picture to the emergency room and pretty soon they're calling a cardiologist when the reality is it could be a spicy dinner that you had, right? It might not even be cardiac related, but I've already pushed it down that path. And so I'm just trying to process this whole conversation like, oh my goodness, how many of these have I pushed down a path of, we're bringing this guy, gal, kid to you again for the 13th time, and we're just at a dead end. And I know as well as you do that you're going to keep the kid on the emergency room bed for however long it takes until they're sober enough. And you're going to release them to the parent, and I'll see you tomorrow. And you realize, like, whatever, $1,500 I quit. Just keep doing this until it reaches, unfortunately, its conclusion, which is often much more tragic.
Well, and for you, the conclusion is either you stop seeing that person because they turn a corner, or it's tragic.
For sure. And so, like, when you think about messaging and you think about language, truthfully, the leap we need to make is to get our EMS people to stop. Like, when I come to you and I give you dextrose because your blood sugar is 28, I don't sit there giving it the, I cannot believe you're choosing this lifestyle. I don't do that. But there are those among us that absolutely do that every time we wake somebody up with Narcan, every time we get to another intox, every time we get to another, you pick the problem. Any mental health issue. My father suffers a bit from depression, also is, he started smoking when he was like 4.5 years old or something, I don't even know. And as you might imagine, as he's approaching upper 70s, he's having consequences of those, of that, what I would call a choice. And it's like to this day, yesterday, I watch him with his little smoke out on the porch and coughing until he can't hardly breathe.
Mhm.
And then he drools a little bit and he goes again. I'm like, I cannot even fathom what you're doing. Like, there can be no joy left in this. And it's interesting, my brother's very educated, and his statement is, I think he knows. I think he knows that it's killing him. I think he knows that it's super bad. And he just cannot cross that bridge and put it down. Cannot. So that becomes a self-spinning wheel of like, I want to, but I can't. I want to, but I can't. I can't. And so the wheel continues to spin faster and faster. And, somebody like me shows up with the ambulance, and I'm worried about a breathing treatment. I'm worried about, trying to keep you alive till we get to the hospital, and thinking the whole time, what are you doing? Why are you smoking? This is super bad for you, with no understanding. When it comes to mitral valves, when it comes to cardiac issues, strokes, diabetic issues, I have been at this a long time. I have published work. I've worked really hard to understand these issues. And so pretty much for that first half hour of our time together, I'm providing basically hospital level care for you. We're doing cardiac monitoring. We're doing everything you would need to get to. But it turns out from the neck up, when it gets into mental health, I'm like, and I just don't understand it. I can't understand it. Like people tell me they hear voices, and I'm like, we all hear voices. My voices tell me to do wash, and like everybody here, I guess my voices aren't telling me to kill people or kill myself, and so I can't. It becomes something you can't understand, and therefore you act out in either a judgmental or an inappropriate way. And so I think as I look toward closing out my career on the fire department, one great thing I could leave them with, and something that my predecessor started, is the logic that this is another medical condition.
Yes.
We're trying to help these people. And so language, attitude, all matter from that traumatic event moving forward. As we paint the picture for the emergency room, as we engage the family. As we engage the family, here's an opportunity right now. You need to talk about this. Like, you cannot bury this. This is, putting this in the closet is not going to be helpful. But then, you have a family member, Jason and I just kind of visited about this, right? You have the family member that says, okay, here's what we're doing. We're going to do blank. Who do I contact? And you're like, what? I don't know. My game was only this deep, right? I don't have those next answers for you.
Right.
And so I think part of, number one, recognizing this as another medical condition, as another disease process, and number two, having an immediate solution of, I want you to call this guy, this gal tomorrow. She will be in the office at 8:30 in the morning, and they are going to guide you on your next path.
Because you would do that over a heart thing.
For sure, yes. Like you can't. I'm not leaving you here because this is, this is super bad. This is going to get worse, and you're likely to die from it. And so that becomes, this. It tears me up every time. One of my drivers in participating in this whole mission is the girl over on just east of here, basically. But she got released from jail. She came home to her parents' house, and her dad called at 9:30 in the morning, and she was laying on the floor, snoring respirations. The crew got there, zapped her with Narcan. She sat up. She's like, I must have had, this must have been in my system. And the dad's like, oh, that probably was in her system. And it's not in her system. It wasn't in her system. Everyone in the room knew that that was the case. And ultimately, they decided that it would be okay if she just stayed with her dad. And we left her in his custody. And at 4 o'clock in the afternoon, she had a fatal overdose. And the dad was standing there crying, saying, why couldn't you take her to the hospital earlier? Why couldn't you do something for her earlier? And the crew just stood there like,
We were here.
yeah, I don't know. We didn't do anything because patients have rights. Patients have the right to refuse. But now here you are at the intersection of death and the family, explaining to the father that that's it. She will not have a chance at recovery now. And it's a talk about an awkward, very uncomfortable conversation. And you're just stuck, and then you're left to kind of dissect that and think, oh, what's next? How will we do this different next time?
Well, I think dissecting is part of the discussion that needs to happen, but you mentioned two things in general. One is the systemic, how we connect with one another. The fact that if that person had had a heart incident, we have an automatic referral source the next morning with a cardiologist somewhere in that person. And so there's a systemic trail. But the second one, which I think is, we can discuss a little bit more here, because systemic stuff we have to work on within our own system, is when you said, I don't always use the right words, but it's the attitude you mentioned. Because I think that's the interesting part to me. It's how the attitude comes across. And you can see it, and everyone around can see it. And you actually, the rolling of the eyes, here we go again, right? Well, that is part and parcel of this disease. But that attitude, I think, is what Guido was talking about before. It's pervasive. We're dealing with, and to use the term, an addict. It's a throwaway term. Consider we're dealing with somebody with substance use disorder, right? There are other medical conditions where I'm sure you get called on pretty routinely, right? As you were telling your story, it reminded me when my mom was going through her cancer stuff and chemotherapy, a neighbor called me and said, your mom is non-responsive. She called me, and I'm 30 miles away. And I said, oh my, does she, no, I think she's breathing, but she can't get her. I called 911. Person showed up. I stayed on the line with the lady. Well, the medication that she was on, she never had diabetes in her life, but now put her into that. And so I'm talking to the EMT, is that correct? And I said, I'm on my way. He goes, don't bother. I'll let you talk to your mom in about 45 seconds. What would he have given her?
You give them the sugar that your body can use, so it's a dextrose solution.
Okay. And I hear, all of a sudden, I hear her go, wow, you're really good looking. And she wasn't talking about me.
Happens all the time.
and he was laughing, but what you were just saying, it wasn't so much what he did, it was how he treated it, right? And I still think about that, obviously. And that's that level of respect, of going through something, of understanding the disease that we don't have when it comes to substance use disorders yet. Not across the board. Many of us have it. When I see somebody at the grocery store, Chris, Karen and I were talking, the Speedway up the block, where there's a lot of people suffering from substance use disorder in the store, right? You may get a call there later today.
Speedway is this one right up here is one of my favorite spots. Dude had a heart attack, put gas in his truck in the morning, flopped over, and the guy next to him ran over, grabbed his wallet, and took off. You could watch it on camera. The guy looked out, the clerk actually looked out, he's the one who called 911, and we got there and the guy was in cardiac arrest, but that guy was concerned about getting his wallet and changed. I'm like,
Wow.
Mike, I would.
Sorry, you're dying, dude.
Glad I just wanted water.
When you're talking about the attitudes and stuff, and I think we talked about language, I see this a lot. My example is more in the domestic violence, but it obviously can be very similar in use. But like when a victim or a survivor does not sign the 72-hour no contact, the report says that the victim refused to sign, implying that she's uncooperative. When she might be scared to death to sign it, it might be the most unsafe thing she can do, he or she, but the language is refused. And for me, it gives me chills when I see that because it doesn't honor the decision and what could be behind that and what's going on there. And so when we talk about language, even in reports and how we're wording, even if someone refuses services, what does that mean? How do we want to word everything? Because that goes into attitude. The attitude of the person describing the scene and setting it up, and the attitude of the person receiving it, and those words in the reports and how we frame that all contributes to attitude.
Well, I think I said it last time, and you said it earlier about as a parent. Jason, when Terry was using, he just used. That was him. It didn't reflect on you. My dad's drinking was my dad. It didn't reflect on me. But I'll tell you what, the whole family thought it did. The whole family conspired because they said it will make us look bad. And that's that stigma of what we're talking about. That there's something about this that would make us look bad. Olivia Newton-John passed away yesterday, right? And all I read yesterday was about her valiant 30-year battle with breast cancer and how everybody rallied around or whatever. Well, her breast cancer didn't reflect upon them. And it didn't mean that they were somehow morally corrupt. But that is still the way we deal with
Well, so I just want to go back to what Karen said about the restraining order, the 72-hour restraining order. Systematically, legislation changed so that they don't have to sign that restraining order. A refusal doesn't mean anything. That means that there's still a 72-hour restraining order in effect. A waiver takes away that 72-hour restraining order, but we still have sort of that stigma that goes with it. Yes, the refusal, but systematically, we looked at that and we realized, oh my gosh, here's the issue. So we've come really far. The eyes rolling and the disdain for people with substance use disorder has been mitigated to some degree, but we still don't have that systematic response of, yeah, we don't care if you want a restraining order or not. We don't care if you want help or not. We're still taking you to the hospital. Here's the mandated response that we did with domestic abuse in some degree. And I think that's where we have to get to.
So what you're saying is that dad should not have been allowed at that moment to say, we'll just keep her here. That legislatively.
Yeah, there has to be a systematic response that says,
mandated to take her to.
Right, there's a greater good, there's a greater concern. I had a loved one who I physically drove to the ER in a state of drunkenness, had been for 3 days. And the ER triage nurse said to him, so Jim's going to be your nurse. And he said, aren't you my nurse? And she said, no, I'm Julie, the triage nurse. You'll like Jim. He likes beer too. Hand to God. I was like, when they say you see red? It had never happened to me before. But his girlfriend was talking to me and I was like, oh my gosh, I stopped listening to you like a minute ago. And I was like, you just said what to him? And she said, who are you? And I said, I'm Guida Brown. Like, not, but I had just been there not a month earlier training the ER staff about the right things to do and say. And she said to him, you'll like Jim. He likes beer too.
You know, back to your point and to this point, if I can figure out in your home that you're having a heart attack, I make the right calls and we activate the cath lab at the hospital. We dress you in a gown, we put translucent electrodes on you, we prep you for surgery, and we don't stop in the emergency room. We bypass the emergency room, we go right to the cath table because that's the fix for your situation. Yet we use these emergency rooms as just dumping grounds or catch-alls, and you know, the great argument is that's maybe not your best. Like, you just feel like you're stuck in the system then again at that point, and it's not moving you forward because you're not getting, you're getting Jim who likes beer too, as opposed to somebody who understands maybe a bit more about your situation. So to that point, you know, I've been incredibly encouraged by our forthcoming partnership with Oakwood and the county to start going out and doing these counselors, these specialist counselors, as we go out to these overdoses within 24 hours and try to get them into a program or try to get them some help. And you know, that's a way better solution than well, let me take you to Jim. Jim likes beer. You'll like him. That's crazy. It's crazy that we just continue to double down on this. And isn't that how you define insanity? You keep doing the same thing and expect different results.
I love that job.
Going in hell. But now again, so when you talked about, you know, the woman who overdosed and was left to and again, I'm saying systematically we have to have a better solution, because saying, well, you're having a heart attack, but we're just going to leave you here because you're going to refuse service, you're going to refuse care, that's okay. That's not okay. It's never okay. And the idea that this last bit of the population is left to their own to say, it's not that bad. Again, my dad had mitral valve regurgitation. My mother had cancer. I know what cancer looked like. I don't have cancer. I'm not that bad. We still let this population define that when we're all in this conspiracy of silence to allow that. And that is the problem. That is the systematic response. Don't even get me started on what we're doing with the opioid money.
Well, okay, so I will get you started on that in a minute. But, yeah.
Having a medical protocol, and what's the medical protocol for a stroke? What's the medical protocol for diabetes?
So are you guys going to do that differently now? You guys are going to do something with recovery coaches?
That is the goal. It's one of these deals where you get super excited to move forward, and then you find that there are just a couple of regulatory hoops to jump through.
Sure.
So it is a process moving forward. It's been I've been through a number of these meetings now, and we have a group on the fire department that is in a couple weeks going to be working with a mobile integrated health consultant out of Milwaukee, and that will be the session that talks about language approach. And the long story short on it, truthfully, is that everybody jokes about it, right? Oh, you people enforce the laws, you people are the authoritarians. When you show up, I could be in legal trouble, but you people are here to help me. Thank you, right? These folks are here to help me. And so you can put a fire truck and a cop car in a school parking lot, and the kids all herd to the fire truck. And the cops will just stand there, right? So it's just life. That's just how it goes. They have the authoritarian role, they have the enforcement role. Our job is not that. Our job is simply to manage your medical situation or to provide help. So we actually will ultimately become the access for the help, right? So while we're part of the solution, our component to that is any house in a 6-block radius from here, even dressed like this, I could knock on the door and they'll have me into their living room. For sure. Come on in, you know? There could be paraphernalia, whatever. They could be doing whatever, but I don't represent the legal side. I only represent the healthcare side. A cop is not coming in their house, right? So we will hopefully provide that access to get somebody who's trained to deal with this in to visit with that person's family, and hopefully we can knock down some barriers in that sense.
So the purpose of talking about this with all of us, and all of you watching this, and I'm sure there's thousands, is stigma. Is that those of you who know a lot need to speak up personally. So when we see the attitudes, first we check ourselves, right? Our attitudes don't reflect that, the language that we use. But secondly, this is the way things get changed systematically, is the system needs to reflect the expertise of the people who know the direction that it needs to go to be the most helpful, right? I wasn't consulted at all about the construction taking place on the freeway. And it's a good thing, because I know nothing about that whatsoever. I assume that they employed people that know what they're doing when they build things like that. Well, that's us. That's all of us. And that conspiracy of silence is what allows those people who have very little expertise dictate how that system works as part of it. It's why for years we had hospitals that had the mental health floor on the 3rd floor, maternity on the 4th, and addiction on the 5th, and they never talked to one another. How crazy is that? I mean, this is in my lifetime where the people who work with addiction didn't talk to the people who work with mental health. When I first started working with you all, we were bringing people together. And people then say, well, wait, could this affect the entire family? Yeah, kind of, you know. And you have to watch, you know, that's the way I do it with you, but it's like, yes, it does with them. So it's 3 things really. Our attitudes, our language, how we interact on a personal level in what we do, and then affecting those things systematically because you have the expertise to do it. And even though there's roadblocks, and it takes a while, the funding, and whatever else, it does get done. And when it gets done, it's more helpful.
We just started a program where we have leave behind kids, right? So inside this bag is a packet of resource numbers, people to call for help, and then we have 2 Narcans and 2 fentanyl test strips and the directions to use them. So at every overdose, we leave those. Right there, right in the home, here you go, there's Narcan in here. You look like the next most competent one here. This is how you jib this in the nose and squeeze. It's honestly that easy. Please do not let someone die from this. That's crazy. It's crazy to have people dying from this. Let's save their life and then work on a way to get them better. And I would say out of 150 people on the department, I would say I have probably around 10% that consider that enabling. We're enabling. You're enabling. You should not be doing this because you're enabling them.
And how many times will those folks use a defibrillator on somebody?
100% of the time.
Repeated.
Does the fire department have demographic data to neighborhoods that have the most calls? And is there anything being done proactively in those neighborhoods, like knocking on doors with those kids before the overdose happens?
Is that what Carrie's doing?
Yeah, that's what Carrie's doing.
Right,
with
and
the,
so
They're doing COVID though.
No.
They're
No. I mean, they're doing both. They're also doing Narcan. They're handing out Narcan. They're having those conversations. That's the human services go. Yeah.
And we provide them every time we go to an overdose and they click the box for an overdose or a possible overdose, those names with a little list of questions appear on a sheet, and that sheet gets sent to the county every morning. Every morning that there is somebody on that case, on that report.
That goes to kids, right?
Yeah, it would be.
So it's, we capture a tremendous amount of data. It seems like we can paint a pretty good picture of what this problem looks like, certainly in our box, but I already know, like Salem Lakes, I already know in the county, they're using our same program. They're capturing the same data. So this is not a leap to actually expand this across all of Kenosha County. But I gotta be honest, there's 3 things that all firefighters absolutely hate. They hate the way we do things, but they hate change more, and they do not like being told what to do.
Oh,
So
okay.
those 3 things,
I think
as long as you can get around that.
almost everyone everywhere, right? That is great.
So, like, it's just kind of interesting as I hear you talk, as I think about the social aspect of it. You know, this is event plus 24, 48, 36, 96 hours. But once again, I think that diagnostic momentum can start with the event. And so our choice of words, our attitude, our spiel for the people at the scene is maybe the better recipe to at least push this in a direction. And it's going to take some work.
When my mom passed away, she was 26 years sober, recovering. And part of the reason why was that when she had me come and pick her up and take her to the hospital, and she was not in good shape. So the person who came out of the ER at the hospital was not the doctor who 6 months prior to that had given her a prescription for Valium. It was this wonderful woman who was a treatment professional who sat down in the lobby of the ER and had the conversation that you're talking about having. You have a problem. You need help. And her approach, and then she just took, and my mom said, yeah, I know. She said, well, come with me. And she just took it. And that was to be, I would have never bet that would be day one. I would have thought, but it was. And that's what you're talking about. That was the bridge. Had she not been there that day, and we would have seen Lenny who liked beer or whatever, or the doctor who wrote her a script for something else, would have been back in there.
So again, I go back to, we need a systematic approach. We can't expect Jason to be standing outside the ER waiting for people to pass by and offering them services. The ER has to offer those services. EMS has to offer those services. We all have to be on the same page to say, this is a chronic, progressive, lethal disease. And without intervention, much like all these other chronic, progressive, lethal diseases, you're going to die without intervention. We don't do that.
One of the things that I wrote down when we were talking about attitude and language is that at every step or level of this process, the individual that's called upon to help somebody struggling has to have the ability and the willingness to have an honest, empathetic conversation, no matter how difficult, right? And that has to be kind of the same type of language, the same type of feeling, and it has to be from that first call that you guys show up and you Narcan, that person sits up and goes, you killed my high, man. Like, look, no, you were dead, right? Like, you're now breathing again. And, whatever that looks like, having those steps through the process, so from the EMS to the ED tech who's doing the triage, to the case manager who's working in the ED, to the med floor, to the ICU, to the hospitalist, to everybody. I mean, like, when you look at it, you go, it should be really simple to do. right? It's really not that difficult to have a little bit of empathy in the roles that we're all playing. But I think it's the ability and the willingness to have the difficult part of that, which is if you continue this, you're going to die.
But I agree 100%. And again, that's all of us on the same page. I think the other piece of that is what Karen said earlier about families, about, well, if my kid's in trouble, clearly I am being judged. And so I don't want to have that conversation because somebody, especially a loved one, can look at me and say, really? Didn't you just get drunk last night? And then it's a whole different conversation. Again, we don't not treat our diabetes. We don't not treat our heart disease. We don't not treat our cancer. But we all don't treat our substance use disorder. And it's so easy to find people to hold up as an example of, I'm not as bad as you are.
You're using this substance, I'm just using
Yeah.
That's my favorite
Weed,
one right
it's
here.
natural.
I feel like, the interesting thing about it is, my handlers will tell me, hey, there's only so much money. We still have to go take care of the heart attacks and the strokes and everything else. And my statement to it is, here's the problem. We have no process, no regulatory path for these folks. And so we don't need to provide these services. We need to initiate the action to get them to the services. And so like that's not a money thing. That's a language thing that gets you to the next most logical step in the path with least resistance. And I don't know, maybe I'll just spend the rest of my career trying to tackle that. But the whole logic of, community health and all the sources, all the resources that exist, there's a huge amount of them.
Yes.
Huge amount of them. But people just can't negotiate it, can't get to the next step. My predecessor, Jim, tells a story about his driver to be involved in this. And he sat at a meeting one day, and the lady stood up and she said, my son's dead, and I didn't know about these services. He's like, that, we'll fix that. We're going to fix that tomorrow. And I think, that's just very powerful about your choice of words, your attitude to help, your logic as we correlate this with other medical conditions. So I question where the best place to start that is. And maybe the answer is it needs to be added to the curriculum for education for providers, EMS providers. Like this is something we learned at the very base level. Your first day on an ambulance is going to be down this path, all part of that regulatory approach or that systematic approach.
Well, you're not wrong about that. And it's not just EMS, it's everywhere. You can say that with physicians. You can absolutely say that with social workers. When I do training for them, I ask them, how much training did you get in substance use disorders? And the answer is almost universally none. Yet despite the fact that that's 90% or more of your job going forward, right? You took a breath.
Because I was going to go on another tangent, but I think Karen needs to wrap this up.
I feel, just on, and I can visit with you after this is over, but I feel like twice a year, once in February, once in September, we get the entire department together across 3 days. That's how I capture 100% of them. And we do, those are training days. So good example, coming up in September, we're going to do a full 3-day session, and we actually pull them out of work, off. There's no other responsibility other than to learn here today. And so we use Strawberry Creek and Estella on alternating sessions. We use their conference rooms, and we capture speakers that help us with these issues. So
Awesome.
I might just try to reach out and see if you have an opportunity.
If
because
I get a souvenir fire hat, that would be awesome.
I can work out a souvenir fire hat for you, yes.
That's a good man.
And a badge.
The red plastic one.
Yeah, if I come home with a badge, that would impress my kids.
Before I say any closing words, Mike, do you have any closing words?
No, this is sure, yeah, I guess the point of this is not to solve, but to motivate to solve. So that we can go back and say, yeah, we're on the right track. I can check me personally in my environment. I can check me professionally in our interactions. And then I can advocate system-wide so that we can get the best policies and procedures that we can. And if we keep doing that and spreading, ripples in a pond, increasing the numbers, when you said 10%, it's relatively low. 90% can get a lot done. 10% we believe can get a lot done. So that's the point of doing this, and I really appreciate you all taking the time to do this. And for the thousands of you, thank you for listening.
Thank you all for listening very much. And I think, as Mike said, we hope this is just a conversation to kind of get some of the ideas going about what is stigma, what does that look like in all the ways it permeates in small and large ways, and to begin to really start delving into your thinking about how do you see it in your world, in your profession, and what ways do you want to look at addressing it and confronting it personally and professionally.
Thanks for
Thank
hosting this.